Welcome to another edition of Surgical Pathology, digital slide review and sign out with Dr. Louis Hassel. I'm pleased to present to you today another nuanced case in pancreatic pathology. This is a 45-year-old man who has a history of familial adenomatous polyposis and has been discovered to have an ampullary mass. Here's a representative image of the lesion. You can see here liver parenchyma, contrast agent filling the common bile duct, draining down towards the duodenum, and then encountering a heterogeneous mass here in the second portion of the duodenum, which has solid tissue characteristics. Looking now under the microscope, here we can see a low power image of a section taken to include duodenal mucosa over here on this surface, the ampulla area here, and then pancreatic parenchyma over here. Here we see a little bit of duodenal wall and some accessory pancreatic ampullary tissue up here. So this is obviously our tumor. Let's look at the interface between the tumor and the duodenum first to get an idea of the kind of epithelium that's present here. Here we can see a combination of benign tissue over here with this clearly neoplastic growth of confluent glands and tissue. Somewhat complex architecture, inflammatory background, mucinous secretion with a moderate amount of inflammatory cells within the mucin. And we see the nuclei have fairly prominent nucleoli, a little bit of mucin production, and complexity. In other areas here, we see a little bit higher grade nuclei, paler cytoplasm, more solid and papillary growth pattern. And this process extends then deeply into the tissue where we see more poorly differentiated single cells infiltrating off into the stroma in varying degrees of disorganization as we get deeper into the tumor. And typically we see a more high-grade type of nuclear morphology as that happens. Coming over here to the interface with the pancreas, we'll look here and we can see, I think you can see here, what looks as though it's a channel or a lumen, maybe with slightly different morphology. And indeed, it does look here as though we have a benign surface epithelium with underlying high-grade malignant neoplasm. So this area here probably represents the residual common bile duct or pancreatic duct as it empties into the ampullary area with an undermining and compressing neoplasm creating the mass effect. It's important, of course, to recognize the origin of the tumor, what structures it involves, because pancreatic and ampullary tumors are staged somewhat differently. And so distinguishing between a pancreatic ductal type carcinoma versus an ampullary carcinoma versus a biliary origin primary tumor is also very, very important. And here it looks as though the tumor is compressing, but is actually not directly invading into the pancreatic parenchyma. Here we'll look at a similar case with slightly different morphology. Again, we can see the duodenal mucosa overlying a mass lesion here that extends down into the muscle wall. of the duodenal tissue. And again, we see areas of what appear to be maybe remnant duct with surrounding more poorly differentiated tissue. Here, however, I think we can see that we have a slightly different character to this epithelium. First, this is more typical adenomatous type epithelium that you might encounter in a tubular adenoma. And then here we have a more solid type tumor that has areas of necrosis and solid and small gland formation. So this illustrates the fact that we can have several different tumor types adenocarcinoma originating in the ampullary area. And as would be expected, they are related to the underlying normal epithelium that can be seen here. So we can have intestinal type epithelium, which is what we see here in this particular case, with intestinal pattern of adenocarcinoma and areas, as I pointed out here, of more adenomatous type epithelium. Or we can have ductal type epithelium, ductal type tumors arising from the pancreatic duct, or even more biliary type neoplasms that may arise from the biliary glands or biliary component of epithelium that can be present. So a couple of fine points to be aware of and to help you understand what you're looking at as you consider a neoplasm in this particularly complicated area of the body where you have several different structures coming together in an important crossroads as exocrine and biliary secretions, hepatic secretions come down together to enter the duodenum in the ampulla. So our final diagnosis today is adenocarcinoma of the ampulla of Vater. We looked at both ductal types, the first case there, and an intestinal type, the second case that I illustrated there, which would be more commonly expected in a patient with familial adenomatous polyposis. Thank you for joining me, and we will look forward to sharing another case with you next time.